Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. C.H. Asrani. Sir is MBBS, DNB, Family Medicine, founder chairman of Infix Group. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is the Immuno-Age revolution, vaccinating the elderly with precision. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you very much for the introduction. I would like to thank the team at IJCP for giving me this opportunity for talking to the family physicians of the country. Immuno-Age revolution. All of us in practice must have realized that immunity of the masses is coming down gradually. And from time memorial, we have been noticing or we have been seeing that elderly as well as infants are a low immunity community. So a new word has been coined, immunosenescence. Immunosenescence is gradual deterioration of immune system with age. And Immuno-Age revolution is how do we fight this? Even during COVID, we saw that people above 60 were considered high risk. They were requested to stay indoors. So immunosenescence is something which we have to look for in future with great detail and great concern. And this immunity going down leads to chronic inflammation, which we can evaluate in our patients with high sensitive CRP. Plain CRP is acute inflammation. High sensitive CRP is chronic inflammation. And this chronic inflammation in the tissues increases the risk of infections, bacterial, viral, fungal, cancers, and other age-related diseases, including atherosclerosis. Can we reverse immunosenescence? As a practitioner of modern medicine, we will be tight-lipped. We will say, no, we are trying. But there are a lot of quacks in the market, especially on social media, who promise to reverse this. Let's take it with a pinch of salt, because this requires a consistent lifestyle management. You can't do lifestyle management for a few months and then go back to unhealthy life. It requires some supplements. I'm not talking of whey protein or creatine or supplements to build muscle. These are supplements of antioxidants, and there are some newer emerging drugs which may help, but they are still in the research stage. So what are the dietary supplements? Antioxidant support. For last about a decade, we have entered the era of antioxidants, which are different than B complex or other vitamins available. We have free radicals in our body which are responsible for atherosclerosis, responsible for cancer, and largely chronic inflammation. In smokers, smoking one cigarette gives 40 free radicals. These free radicals, even in non-smokers, come from pollution, come from foodstuffs containing fertilizers and other chemicals. Maybe coming from cosmetics also. So, antioxidants nullify these free radicals. That is why the future of dietary supplement are antioxidants. Vitamins C and E. I'm not talking here of 500 and 1000 milligram of vitamin C every day or 400 units of vitamin E. That much high dosage can give side effects. These are moderate amounts. Minerals like selenium and zinc, flavonoids, lycopene, and carotenoids. Most of these are available in nature, but some supplements may be given to elderly people. Fruits, berries, and citrus, vegetables, leafy greens, tomatoes. You may be surprised to know that a tomato contains more vitamin C than an orange. Nuts, limited quantity, few almonds, few walnuts, maybe 5 almonds, 2 walnuts, few pistachios, and non-diabetics can take up to 8 to 10 raisins. Whole grains, seeds, not refined grains, refined flour, and at times even coffee and tea. A lot of people take green tea saying that it gives a lot of antioxidants, but there again, limit the consumption to 2 cups a day. The properties of food that change our immunity, it is through these compounds that I just described. Vitamins, minerals, fatty acids, flavonoids, and probiotics. Probiotics work wonders for increasing the immunity of our GI system. Again, repeating, vitamin C from citrus fruit, beta carotene from carrots, omega-3 from fatty fish, salmon in India, ravas, probiotics from fermented dairy, and curcumin, the age-old haldi from turmeric. I have a simple rule that I tell my patients. Anything in nature that you see colorful is rich in antioxidants. So when you're buying cucumbers, better go for green, wash them well and don't peel the skin. Go for tomatoes, go for berries, go for broccoli, if the pocket permits. But everything colorful in nature is antioxidant. Then comes the question of, I have given supplements. Now why immunization? It's a widely accepted belief that the best cure is prevention, and it is also most economical. A patient who needs to be admitted for pneumonia in a government hospital may still have to purchase antibiotics from out worth 10,000. Hospitalization may cost around 1 to 5 lakh depending on grade of hospital, and then the risk of morbidity and mortality. This applies to individuals as well as populations, communities, and immunization is the key to achieve that. We have just experienced few years ago when COVID hit us. Childhood immunization is on. Till about 5 years ago, we had to convince people to take adult immunization, but now it has been accepted by the community. Still, as a doctor, you should be able to convince a patient, counsel a patient that how it is going to help. Till COVID, protecting adults through vaccination was never discussed. It was only when you are traveling overseas, people would take it mandatorily. But otherwise, adults vaccination, people thought doctors were only making money. it's wrongly assumed that adults are less susceptible. Few years ago, when in Bombay we had an epidemic of H1N1, we had a tough time convincing people to take vaccines. Sorry, one second. What I would tell them, the vaccine is 2,500. The swab test to check for H1N1 is 5,000. Even then, people were reluctant to take the vaccine. Even WHO has now added, CDC is always recommending adult vaccination, but WHO has now started saying that adults should be vaccinated. I just give an example of economic consideration during H1N1. Let's talk of pneumococcal vaccine first. Because people with low immunity, especially elderly, are more susceptible for pneumonia than they are in influenza in India. Vaccines help prevent any type of illness caused by Streptococcus pneumonia. There are two kinds of pneumococcal vaccines. Pneumococcal conjugate vaccine PCV 13, 15, PCV 20. 13 and 15 are usually given in childhood in the recent times. But people who were born prior to 1970 did not have the luxury of PCV being available and part of the Indian immunization schedule. And then we have pneumococcal polysaccharide vaccine PPSV 23. So how do we administer them? For those who have never received a pneumococcal vaccine in their childhood, I will give them one injection of PCV 13, that is brand name is Prevenar, which is once in lifetime. And 2 to 6 months later, one shot of pneumococcal polysaccharide vaccine 23, which has to be repeated for every 5 years. If a person has taken the PCV vaccine in childhood, but now for some reason, still in young age has suffered 4-5 attacks of pneumonia, I can continue giving a pneumovax or a polysaccharide vaccine directly without giving PCV 13. Adults 19 through 64 year with certain medical conditions or risk factor. Adults below 65 who do not have any major illness need not be given pneumococcal vaccine. PCV 15 is used, followed by a dose of PPSV 23 after 6 to 12 months. With 13, we give after 2 to 6 months. Then every 5 years. As a practitioner, you should have a facility to call the patient a week before the vaccines are due, because it makes very good business practice also. The brand names available of PCV are this. Commonest being used is Pfizer Prevenar 13 and Pneumovax MSD PPSV 23. Other ones are Pneumo 23 Sanofi and Pulmovax of Lupin. So repeating, if somebody is not taken, like I had a patient day before yesterday, 69-year-old, never taken PCV, so we gave Prevenar and we called after 3 months for PPSV. If a patient has taken Prevenar, that is once in lifetime now. In childhood, they are given multiple times, 3 times. Then only PPSV every 5 years. recommended for all adults 65 or older, even if of so-called normal immunity, because they are suffering from immunosenescence. Then 19 to 64, immunocompromising condition, chronic diseases, heart, lung, liver, people have undergone surgery for valve replacement, uncontrolled diabetes, HbA1c above 8, and any kind of autoimmune disorders. You will agree that lately autoimmune disorders also are increasing much in number. We are seeing more cases of lupus than we have ever seen in our lifetime, and a history of invasive pneumococcal disease in past. So one or two episodes of pneumonia, bacterial pneumonia, you have to start giving pneumovax. For healthy adults, as I said, under 65, vaccination is not usually recommended, but only those who are high risk can be given. Influenza vaccine type 1, this can be given to anyone from childhood onwards. They protect against 3 or now 4, because now we have tetra influenza viruses that research indicates are very common. These vaccines have been given routinely in Western world because influenza is much more common there. But in India now also it's becoming common. These vaccines are given either intramuscular or subcutaneous. Please check the packet of the supplier whether it is IM or SC. All may not be same. Types available are trivalent inactivated influenza, Influvac, and now it is quadrivalent. So we have Influvac tetra and we have Fluorix. All people 6 months of age and older can be given on an annual basis, especially people with chronic medical illness, immunocompromised individuals having high risk of influenza like pregnant women, and all people above 65 or older. I have seen one thing, even though not classical influenza, people who are getting allergic rhinitis and cold without any sinusitis symptoms also benefit by giving influenza vaccine. Schedule is single dose intramuscular subcutaneous 0.5 ml annually. Who should not be given? Moderate to severe illness with fever. So my patient has a due date today but has a fever of 101. I should not give, I will postpone. Past history of Guillain-Barré syndrome following influenza vaccine. History of immediate hypersensitivity reaction to eggs. Egg albumin, eating eggs and immediately getting a edema or urticaria should not be given. Allergic to any of the ingredients or formaldehyde, gentamicin sulfate or sodium deoxycholate. These are rare, but you have to ask. These are the brands available: Influvac, Abbott Tetra, Fluorix, Vexiflu, Zydus, Zuvi, Flu. Type 2 influenza vaccine, live attenuated influenza vaccine, healthy non-pregnant individuals 2 to 49 years only. This is not for adults, but I'm still covering just to complete the topic. It's intranasally annually. Not to give above 50 years or below 2 years. Pregnancy, people with immunosuppression, you might as well give injectable because this is live attenuated, and chronic medical conditions. Close contact with severely immunocompromised. So caretaker of an HIV patient, a caretaker bedridden patient of diabetes. One of the newest entrants in the vaccine market is herpes zoster vaccine. Adults 50 and older and those with immunocompromised status or condition. It prevents shingles or herpes zoster as well as post-herpetic neuralgia, which we all know can be a very serious problem. Given a two-dose series with second dose 2 to 6 months after the first, common side effects are temporary and local, not anything systemic. There are two brands available, Shingrix of Glaxo and Zostavax of Merck. Shingrix is non-live recombinant subunit, whereas Zostavax is live attenuated vaccine. This is two intramuscular injection, 0 and 2 to 6 months. This is single subcutaneous. But when you see the efficacy, the Shingrix is 97 and 91% effective against people 50 to 69 and 70 above, whereas this is effective only 51%. So it makes sense to give Shingrix. I'm not being sponsored by Shingrix, but I'm just giving you the cost effectiveness. And even against post-herpetic neuralgia, Shingrix is more effective than the live attenuated vaccine. Hepatitis B virus vaccine, we have been giving it for a long time. Most of our patients have had, but again, today I have a patient of 75 who's about to go on dialysis. I'm sure he is not been given. So there is a recombinant DNA vaccine available. All unvaccinated adults who are at risk of contracting HBV infection. HBV infection is unsafe sex, blood and blood products, and body fluids. So people who are undergoing dialysis, people who are undergoing blood transfusion should be vaccinated. Schedule healthy adults 1 ml 20 microgram at deltoid, 0, 1 to 2 or 4 to 6 months, at least 4 weeks between dose 1 and 2, at least 8 weeks between dose 2 and 3. CKD patients and other immunocompromised patients, chronic liver disease cirrhosis, CKD, they should be given double the dose, 2 ml 40 microgram, and they are given 4 doses, 0, 1, 2 and 6. We give 0, 1, 2 and 6 also where there is a rapid conversion desired. Like I have a patient who's going to get married to a hepatitis B positive patient, knowing very well, then I would give 0, 1, 2, 6. Those being readied for maintenance hemodialysis, 2 cc at 0, 1, 2, 6. In these patients, I have to check anti-HBs to show that patient has converted, got seroconversion and immunity has established. Otherwise, we may have to repeat the vaccine. Those in a hurry, as I explained, 0, 1, 2, 6. Booster doses are not given. 3 doses are enough for lifetime. Protect against HBV-related CLD and cancer liver also. HPV, there are 2 types available now, HPV-4 quadrivalent, HPV-2, and now 9-valent vaccine has come of a brand Gardasil, which is costing around 10,000 rupees each dose. In September 21, Merck launched first gender-neutral HPV vaccine, 9-valent HPV vaccine for Indian girls and women 9 to 26 and Indian boys 9 to 15. Here we have to counsel our patients to give the girls below the age of 13 because then only 2 doses are required. You cross 14 and then you have to give 3. Females, either HPV-9 or HPV-4 recommended for routine vaccination at age 11 to 12 years and for those ages 13 to 26, if previously not given. For males, again the same vaccine, same ages, but in male we don't give about 21, we give, in females we give up to 26. If not previously vaccinated, males 22 to 26 may be vaccinated, but after counseling that the protection may be limited. Male having sex with male especially benefit by prevention of condyloma, warts, and anal cancer. If not previously vaccinated, females above 27 should not be offered HPV vaccine because the efficacy is not much. Few years ago, we were giving till 35, but the new guidelines say above 27 not to give. The reason being that most are infected with HPV by age of 26, more so if multiple sexual partners. This vaccination I'm just covering because it is not for the elderly. Dosing 2 doses below 15 years. Second dose should be given 6 to 12 months after the first dose. And when you are giving elderly one, it is 0 to 6. 0, 1 to 2, minimum 2, and 6. 3 doses are recommended for those immunocompromised, including those with HIV, but again 9 to 26. Miscellaneous vaccines, hepatitis A, travelers with risk factors, 2 doses, 6 to 12 months apart. Varicella, chickenpox, all adults without immunity, because chickenpox in childhood is a very innocent illness, but in adults above 70, it can be fatal also. Nowadays, adults who are traveling to US are insisted on taking a Tdap, tetanus, diphtheria, pertussis, which is to be given once in 10 years if they are frequent travelers. And for some cases, typhoid, I recommend for people going for Kumbh Melas or similar locations where huge crowd is expected and level of hygiene is not expected to be good, then we can recommend a typhoid vaccine also. All willing influenza annually, mandatory above 60-65 years of age. All diabetics, immunocompromised, CAD, CKD, any autoimmune disorder, influenza yearly, PPSV every 5 years. Typhoid is eating more of roadside food. HPV, all girls, women as indicated. But more than vaccine, it's time that we start advising our people to take more of salads. People say, Doc, what is the use? Everything is adulterated. So take double the quantity. I will tell you one advantage of antioxidants. About 30 years ago, when HIV medicines were unaffordable to our common population, I had read in a book that antioxidants help. I had two sisters who got infected through their husbands, two brothers, two sisters. Two brothers married two sisters, and both were HIV positive. They died. These girls couldn't afford. They were told to take 400 to 500 gram of antioxidants, leafy vegetables, salads, fruits in a day. And believe me, for almost 15 years, they did not suffer from any opportunistic infection, nor did they have any weight loss of even half a kg, 1 kg. So antioxidants are magic, and as practitioners, we should consume them as well as advise to our patients. Thank you very much. Any questions?
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up. So, sir, the first question is, how is the concept of precision medicine begin applied to vaccination strategies in generic care?
Sorry, I didn't hear the first part of the question. How did?
Yeah. So, how is the concept of precision medicine being applied to vaccination strategies in generic care?
See, we have to identify our high risk population and we have to protect them from specific ailments as well as overall immunity increasing. That is how it has been done. And for special research in special conditions, it has been still under research, and I am not qualified enough to comment on that.
Okay, sir. The next question is, are there any promising next generation vaccines designed specifically for the aging immune system?
See, there is a talk of malaria and dengue vaccines being under process, and even Government of India guidelines on vector-borne diseases mandates that elderly, if malaria and dengue, should be admitted without waiting for platelets to drop or bleeding to occur. So these two vaccines I think are coming in soon, and in India we would welcome them with open arms.
One last question, sir. What is the future of geroimmunology and its role in enhancing healthy longevity?
When you say zero immunology,
Yes, sir.
XERO,
Sorry, GERO, Gero.
zero immunology, okay. See, basically, we all know that our younger generation also is now suffering from low immunity. And even healthy people, by the time they enter 60s, suffer from immunosenescence. Our younger generation is going to fall sick too often. You know, we all see that today we are getting acute MIs in 40, 45, 50 bracket. That is because of 15 years of chronic inflammation, which has occurred due to low immunity and bad lifestyle. So it is going to be a tough fight, but we have to keep talking of our patients to our patients. You know, sadly, the practice that has come in market today is pick up a pen and write a prescription. Senior doctors, busy doctors don't have time to talk to patients. You have to convince, not just advise, have healthy diet. You have to convince what to eat, what not to eat. Then only we can achieve a healthy elderly age. And elderly are going to live longer. Let's give them healthful time rather than sick time.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, any take-home message from your end?
No, ma'am, I think we have to spend more time with our patients, talking. And I at least tell my patients, see, I have spent 5 minutes with you explaining. I would have spent less cases, less time by just picking up a pen and writing a prescription. So we have to talk to our patients. Very simple. And we have to inculcate that in our life. And if we do ourselves, we'll be more inclined to talk to patients. Thank you.
Thank you so much, sir, for joining us today. It's a pleasure to have you here, sir. Thank you so
Thank you.
much.
Thank you very much. Bye.
Bye, sir.